So we're going to move on now to cardiac screening. We've talked a little bit about the most common causes of sudden cardiac death, and so Daryl quite nicely introduced a lot of the things that I'll be talking about, so I'll skip through some of my slides and focus on the screening process and how best to accomplish good screening practices. So the issues related to cardiac screening, there are three basic issues. So there's who should be screened, how should they be screened, and when should they be screened. So the current recommendations are that all student athletes should have a detailed history and physical prior to participation in school-sponsored competitive sports. And this examination should be repeated on a bi-yearly basis, although that usually translates to a yearly basis. And the goal is to reduce the incidence of sudden cardiac death and the preventable sports injuries. So by definition, then sudden cardiac death is a death that occurs within 1 hour in the onset of symptoms in a person with significant and previously unrecognized cardiovascular disease. And a competitive athlete is anyone who participates in organized team activity that requires competition against others and usually involves strenuous and intense physical training. In the US, Daryl got you some better numbers than I did, but at least 5 million and probably closer to 16 million athletes in high school, greater than 500,000 and probably much greater than 500,000 athletes at the college level, and then at the professional level, another at least 5,000. So the challenge is estimated that approximately 50,000 children and adolescents would have to be screened to detect 200 athletes who are at risk for sudden death and 1 person who would die. So what is the most responsible way to identify students at risk? So this is a picture of what's probably a little bit overkill, which is a treadmill examination in a 7-year-old. This was probably done for another reason, not a regular physical. But so the important components, so what is a reasonable approach to performing cardiac screenings? So history and physical examination, and the American Heart Association has come up with generalized guidelines that should be used in any good cardiac screening practice. And this consists of a detailed family and personal history and a directed cardiac examination. Unfortunately, there's been a tremendous amount of both state and regional variation in the forms that are used and in the expertise of the people performing the examination. There's no really regulation or guidelines as to how the screening should be done. And so one of the efforts that we'd like to work with Daryl and other groups around the state is to really come up with some formal guidelines about how the screening should be done in order for it to be done in a responsible fashion. The sensitivity and specificity of how good the history and physical is at detecting cardiac disease is a little bit difficult to know because of the variation in practice. So there's been a very inconsistent approach to how the physical and how the histories are being performed, and really to understand how effective it's going to be, we really have to implement it to its fullest extent. We can't partially do it and then try and evaluate how we're doing. So one of the extra tests that's been talked about a lot, and both Daryl and Charlene alluded to this, was the electrocardiogram and what role does that have? It's currently being used at the professional level and by the International Olympic Committee and in several international sports leagues. It's more sensitive than the H&P alone. And can be helpful in determining, identifying patients with hypertrophic cardiomyopathy and arrhythmic right ventricular dysplasia. In Italy, as was mentioned earlier, the ECG is part of the initial screening process. In the United States, it's been something that's been added if there's something that comes up on the initial screening that's of concern. And why is it so controversial? And Daryl touched on this quite extensively, but there is a high number of false positives with the test, leading to unnecessary additional testing and an inappropriate disqualification of a lot of athletes. There are people that are working on strategies to make the test itself more sensitive and specific, but it still would lead to additional testing in approximately 2 to 5% of the cases, which if you add up over 10 to 15 million high school students, that's still a lot of extra testing that needs to be done. Not cost effective. As we mentioned, there's high rates of additional testing that need to be performed because of the high false positive rate. And there is, fortunately, a lower prevalence of sudden cardiac death. Charlene discussed some of the issues related to how difficult it is to get a good handle on how frequently this is occurring. Probably one of the more concerning aspects of the ECG is that it doesn't detect all the cardiovascular disorders that can cause sudden cardiac death. These include coronary artery anomalies, coronary artery disease like we see in the adult patient, and some percentage of the cardiomyopathies and ion channel or electrical disorders of the heart also are very difficult to identify by just ECG. And then the feasibility that Daryl touched on is how practical is it to do that in millions of students? And how many expert ECG readers do we have to interpret those tests? So this is, again, something that Daryl touched on with the national programs that have been done in both Italy and I am going to use the laser pointer for this, both Italy and Israel. And in purple is the sudden death rate in Italy at the time that they started their screening process, and then after implementation of general ECG screening program. And you see that there's a drop in the incidence of the sudden cardiac death. This is the death rate here, and these are the years that they were followed. And then this was followed up by a study in Israel where, again, after a spike in the number of sudden cardiac deaths that they were seeing, they implemented a screening program, and they as well saw a fall in sudden cardiac deaths. But what they noticed was as they looked back in the before and after the screening program is that the incidence rates of sudden death were about the same, that they hadn't really made much of an effect. What had happened was that they'd had an unusual spike in activity, that they'd implemented a program, and then saw what was probably a natural fall in the incidence of sudden cardiac death. And then on the bottom is our program from the United States that looked at the incidence of sudden cardiac death in athletes and found a much lower incidence than they were seeing in Italy. So this just points out that there's some controversies with the ECG screening process, and that based on the data available, the American Heart Association came out with a series of recommendations as to what they felt would be a responsible approach to cardiac screenings. So here's the AHA guidelines as were established in 2007. And it starts with a very good personal medical history. Has the student ever had exertional chest pain, unexplained syncope, dyspnea or fatigue, or a history of heart murmur or systemic hypertension? And I'll go through these again. Physical examination and family medical history are extremely important. It requires parental verification, and referral to a cardiologist or extra cardiac screening is recommended if there's one or more positive findings based on this initial screen. So our interest came from trying to determine how good the screening practices were around the state. So these were the AHA guidelines. How are they being implemented at the student level? Are these recommendations really being implemented? So we came across the old Michigan High School Athletic Association form and found that even the old state form wasn't being used by all the high schools. So that we found in our survey a couple years ago that 63% of the schools were using an official form. The other 37% were using their own forms. So I don't know where they got them from, but they were just kind of made them up. 75% of the middle schools were using this state form. But the state form that was being used only had 5 of the 12 AHA points being evaluated. So there are a lot of parts of a good cardiac screening that were being left out of the old state form. And there was no questions at all about the family history. And Lisa highlighted that very nicely, is that you really need to take a very good family history. And there were no questions about the family history on the old Michigan form. And then this form was replaced in 2010. And the scary part is that many schools are still using this form. As a matter of fact, when I filled out my son's own form for his participation, after I'd worked, to help with updating the Michigan form, I found out when I filled out my own son's form that they were using the old state form. So it was a rude awakening. So here's the new form for the Michigan High School Athletic Association. It's 4 pages long, so you can't miss it. It covers all 12 AHA points, and it's available for downloading from the Michigan High School Athletic Association website. So one of the things that we wanted to stress was the role of the primary care provider in the screening process. So what are the role of the pediatrician? What are their responsibilities? What are there's a lot of cardiac screening events that go on at local high schools. So what balance should there be between these large mass screenings and what goes on at the child's regular pediatric care? So we felt very strongly that sports screening should not replace primary care visits. Sometimes that's the filling out the sports participation form is what gets the child into the pediatricians to be seen. And at that visit, there's a lot of other things that go on. There's substance abuse counseling, there's obesity, things that are dealt with. So there's a lot of things that will go on at the primary care that is not done in a mass screening for sports participation. We don't want sports participation screenings to replace the primary care visit. The cardiac screenings, we also felt very strongly, as Daryl's mentioned and Lisa's mentioned, that it shouldn't be restricted to athletes, that these sudden cardiac death can occur in the non-athletes. So they're slightly higher risk, or they are at higher risk when they participate in sports, but most of their time is not spent in sports activity, so they're actually at very high risk for sudden death when they're not participating. Likewise, non-athletes are at high risk. So we feel that cardiac screening should not be restricted to athletes, and that all students should be included, and that we wanted to reinforce to the pediatrician that updated state forms are now available from the Michigan High School Athletic Association. So who to refer for further testing? So what parts of the AHA recommendations should alert you that more testing needs to be done? So starting with the personal history, unexplained syncope. So anything, and that's kind of defined as anything other than a simple faint. And the simple faint is what they call classic vasovagal syncope, usually has a prodrome, so you know it's coming on. Somebody doesn't feel so good, they don't look so good. They're sweating, some tunnel vision, lightheadedness, and there's usually an inciting factor, something that set them off, either seeing blood, nausea, prolonged standing, or being dehydrated. And that kind of falls in the category of a simple faint. If it doesn't fall in that category, then they really need to be referred for or get additional testing for evaluation. And then exertion, anything with exertion. So if you ask if there's been any symptoms at all with exertion, like exertional chest pain, this is exertion. This also gives me a chance to show my son is running. So exertional dyspnea or fatigue. So as Lisa mentioned, one of the common presentations for HCM is being diagnosed with exercise-induced asthma. So that can commonly masquerade as a true cardiac disorder. History of a heart murmur, and then high blood pressure. So who to refer for further testing based on family history. So what in the family history should alert you? So in the family medical history, the 3 points are premature sudden cardiac death in a relative before the age of 50, or significant disability from heart disease in a relative before the age of 50. And then it's very important, I put this in yellow to highlight it, is that you really need to ask about specific diagnoses: long QT syndrome, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, ARVC or ARVD. And the reason is that you can ask about if are there any heart problems in the family, and they'll say no. And you do say, does anybody in the family have cardiomyopathy? And they'll say yes. And so that would seem to be counterintuitive, but sometimes they may not put that together. So if you can give them specific names of different diagnoses, that can trigger, oh yes, I heard that one of the people in our family has that. I put this pedigree up, so this is how we demonstrate family relationships, and these are, so this might be a student that you're screening, these are his parents, these are his grandparents, aunts and uncles, and this is a family where there's been long QT in the family. And so you're evaluating this individual for long QT, and you ask about his family. Well, and the affected people in the family are here represented with black circles. So his immediate family, there's nobody else affected. So if you ask, is there any family history of long QT syndrome in your immediate family, he'd say no. Well, how about your extended family? So aunts, uncles, cousins, grandparents, is there anybody in the family where that has long QT syndrome, has hypertrophic cardiomyopathy? And I can't stress enough how important it is to get a good and very detailed family history. The events are rare, so these events of sudden death or near sudden death can be very rare, may skip generations. So you need a high incident of very detailed family history and a high index of suspicion. And one of the things that I really want to stress is that it's important to fill out the form before they get to the visit. So that they come to the visit with the cardiac screening process with this form at least already filled out in terms of the family history. Because a lot of times when you're talking to them in these mass screenings, you'll say, well, what about the family history? And they'll say, well, something happened to Uncle Joe, but they won't know exactly what that was. So if you can give them the form ahead of time, have them fill it out, have them talk to Uncle Joe, and find out what happened, you can get a much more accurate and informative family history and pick up things you might not have otherwise if you just fill out the form kind of on the spot. So who to refer for testing based on physical examination? So a heart murmur is a good reason for referral. As Lisa mentioned, many patients with hypertrophic cardiomyopathy are initially carry the diagnosis of an innocent murmur. So if there's any murmur that you think that somebody thinks requires further evaluation, that should be carefully evaluated. Reduced femoral pulses can be present in patients with coarctation of the aorta, a narrowing of the blood vessel that goes to the body. Increased upper extremity blood pressure can be either hypertension or, again, related to a narrowing of the blood vessel that goes to the body. And then marfanoid stigmata. Charlene, I think, mentioned briefly Marfan syndrome. And this is a very, very old picture of two patients with Marfan syndrome. They tend to be very tall, so they tend to populate the basketball, volleyball teams. Very long arms and kind of spider-like fingers. They can have some chest deformities, scoliosis and vision problems. And they are prone to rupture of their big blood vessel that leads to the body. So that's very important to pick up as part of the physical examination. So what about the non-athlete? So as I mentioned before, most deaths, even in patients with hypertrophic cardiomyopathy, do not occur on the sports field. Students with cardiac conditions may not try out for sports. If they've always noticed that they can't quite keep up with others, they may not participate in sports. So, and then non-athletes are people too. All students should have an AHA, whether or not they're participating in sports or not, they should have an AHA-approved cardiac screening to help detect risk of cardiac events in them as well. So what should we be doing for screening? I think that what makes the most sense right now is to do a very complete and detailed personal and family history and physical examination using the updated and approved MHSAA form, which complies with the AHA guidelines. If there are any positive responses on the physical examination or the history, pursue further workup and possibly cardiology referral, where additional testing can be done, ECGs, echocardiograms, stress testing. And one of the things I wanted to highlight here is that there's no one test that's perfect for everybody, and that's why that's what makes it so challenging, is that depending on the symptom, depending on the family history, we may order one or more of these tests, and so it really varies by the individual which test will be most helpful. And then take symptoms very seriously. So Lisa mentioned that as well, is that a lot of patients with hypertrophic cardiomyopathy, before they have a sudden event, will present with some other symptom, whether it be fainting, some dyspnea when they're exercising, or shortness of breath with exercise. So take any symptoms very seriously and really evaluate them to determine if a further cardiac workup is indicated. So the challenge, this is another picture of Reggie Lewis, who came through a very detailed cardiac screening program, but they didn't really know how to counsel him as what his risk would be. So he continued to play sports, and then, as you know, died suddenly while playing basketball after being evaluated by the best cardiologist. So even the best screening program done by the best cardiologist is not going to identify all patients at risk for sudden cardiac death. So once you've identified the at-risk athlete, how much do you restrict them? And are you ready if the person you've restricted from sports has an event in class? And as I mentioned before, most deaths with patients with hypertrophic cardiomyopathy don't occur on the sports field. We need to be ready within the school by having, as Gerald mentioned, AEDs in the school with people trained and knowing how to use them. Since our cardiac screenings aren't going to be perfect, and since these events are going to continue to happen, we need to prepare the school in case of that event. So, and that'll be the topic of our next talk. It'll kind of lead into Dr. Monica Goebel, but before I do, I'd like to thank the people who made this possible. I'd like to thank all the people in the CVC, Charlene Day and again David Pinsky. My support, I'm a pediatric cardiologist, so I've gotten a lot of support from Valerie Castle on this. The Congenital Heart Center, the other pediatric cardiologist, Adam Keene, who's here tonight, is one of our pediatric cardiology fellows who's been very active in getting this program off the ground, and John Sharpie, who I work with and has helped strongly support us in this effort. And then also like to give a shout out to the U of M Clinical Simulation Center, who will be running the AEDs and CPR training in the next room.